In Chapter 12, we will discuss seminal fluid analysis. Why do we perform testing on seminal fluid? Infertility issues is a primary reason to test. More often, there's a problem with the woman, but the less risky procedure to do is to first rule out the male. He is a very simple, painless procedure to perform, whereas with a woman, it is very invasive. With assisted reproductive technology, greater emphasis is placed on sperm quality and quantity. For forensic analysis of a fluid as being semen, as in an alleged rape, vaginal swabs, washings, or scrapings are microscopically evaluated for sperm. Chemical tests for an enzyme acid phosphatase, and I want you to remember that. Sperm donors for artificial insemination programs, we need to know that they have the high count, they have the motility that can result in a successful pregnancy or fertilization. Post-vasectomy, this test is performed at 1-month intervals until 2 consecutive months are negative for sperm. You don't want to have a surprise package, and I've known of cases where the vas deferens, once it's cut and tied, somehow it decided to reconnect, and the woman got pregnant, and the husband accused her of infidelity because he said, well, I had the vasectomy. Well, they did a test on him, and he had never gone back to verify that he did not have sperm in his semen. And yeah, it was his fault. The sperm cells needed to fertilize the female egg, producing a new life, actually make up only a small amount of the seminal fluid, 2 to 5%. The majority of the seminal fluid comes from the seminal vesicles, and contributions to the fluid are made from the prostate gland and the bulbourethral glands. The seminal fluid is composed of various enzymes, amino acids, citric acid, electrolytes, zinc, and sugars to nourish and support the sperm during storage, and also aid them by providing the appropriate environment for their survival and transport through the female reproductive system. And I have to interject here, it just makes me very annoyed when we're talking about seminal fluid. That is the fluid without the sperm. And once the sperm is combined with the seminal fluid, we then have semen. So when we're looking at the examination of seminal fluid, that's not the correct term. We're looking for the examination of semen. The following diagram, which is found in your textbook on page 289, lists the major structures of the male reproductive tract. I want you to be able to identify and state the function of each structure involved in the production and delivery of sperm and semen. This diagram is in your textbook. Be sure to carefully study it and memorize those structures that have to do with the formation of seminal fluid and sperm. Spermatogenesis is the formation of spermatozoa. Sperm mature in the epididymis, and by the end of the maturation phase, the normal sperm cell has developed a head, a midpiece, and a flagellum-like tail. It takes about 74 days to complete the maturation cycle. The spermatogenesis is controlled by hormones such as testosterone. This diagram is in your textbook, and it's a schematic diagram of spermatogenesis from germ cells in the seminiferous tubules. Mature sperm are stored in the epididymis. They then enter the vas deferens, which leads to the urethra. Fluids are added by accessory glands, the prostate, 2 seminal vesicles, and 2 bulbourethral glands. Semen is complex and contains various substances such as fructose, flavin, proteins, prostaglandins, citric acid, zinc, and the enzymes which are proteolytic enzymes and acid phosphatase. The specimen collection process needs to be clearly communicated to the patient. For fertility assessment, it's essential. We need to have several samples over a 3-month period with abstinence between 2 and 7 days before collection of each sample. That means no ejaculation at all by any method. The entire ejaculate is collected in an appropriate, clean, sterile container, and the samples are delivered to the laboratory within 1 hour and maintained between 20 and 40 degrees. The collection container should be kept at room temperature or warm to approximately body temperature, and the time of collection needs to be noted on the sample. So this is the detailed step-by-step process for semen collection. And you not only give verbal instructions, but you also give written instructions, because especially if a woman is explaining this to a guy, it can be very embarrassing to them. And some men, I don't care, just tell me what I need to do and I'll get it done. You must have a sterile container, because if an infection is suspected, we need to have no introduction of outside bacteria to the sample. Direct deposits are preferred. No lubricants, no spermicides, and no condoms. Condoms are coated on the inside with anti-spermicidals. So if you collect it in a condom, you've just killed all the little guys in there that we need to see move around. You must have a complete specimen. The majority of the sperm are in the first part of the ejaculate. So if they miss and part of that goes wherever, then don't even try to submit that, because you will have an unsuitable sample and the results will not be good. 3 days of sexual abstinence are required, but not more than 5 days. So again, be sure to explain to them what abstinence means. It does not just mean sexual intercourse. It's best if it's collected at the laboratory site. And here in Austin, we have a lab that's the semen capital of the world. And they have rooms where the men go. They take their sample cup, they go in, there's magazines, there's videos that will get them in the mood to be able to provide a sample. And then they submit it to the laboratory right there, because if not, you have to keep the specimen warm and delivered to the lab within 1 hour. I've known women who, when they have the container, they put it under their shirt, or they just keep it warm against their body, because it's crucial that this be maintained warm at body temperature and delivered within 1 hour, because these little guys are going to start dying, and the things that we're looking for the macroscopic analysis are going to change. The time of collection is very important and must be recorded. So what are we going to measure in a semen analysis? Well, we're going to measure the color, or look at the color, or the volume, the viscosity, and the pH. Normal semen will appear opaque or translucent and can exhibit several normal colors. The typical colors include light gray, white, and light yellow. The higher the flavin concentration of semen, the darker the yellow the color may be, and this is one of the components of multivitamins. A deep yellow color has been associated with certain drugs. Brown or red semen may contain blood. A highly turbid semen specimen often will contain leukocytes and may indicate a reproductive tract infection or inflammation. The leukocyte esterase part of the urine dipstick may be useful to test to see if this is present. The volume and pH of semen is measured, and the semen volume is measured by using a serological pipette or perhaps in a small graduated cylinder. The volume is recorded in milliliters to 1 decimal point, like 1.0 mLs. The normal volume range is from 2.0 to 5.0 milliliters for a complete ejaculate. Volumes both lower and higher than this range have been associated with infertility. Seminal fluid should be in the range of 7.2 to 8.0 and is measured using pH paper. This normally slightly alkaline pH is to neutralize the normal acidic environment of the female vagina. More acid pH may indicate that the prostate gland has contributed more fluid, while a stronger alkaline pH may indicate the presence of an infection. Semen coagulates immediately and should liquefy within 30 minutes. If coagulation does not occur, it must be reported, as this may indicate a congenital bilateral absence of the vas deferens and seminal vesicles. Normal liquefaction occurs between 30 and 60 minutes after collection. Greater than 60 minutes is abnormal. and specimens that do not liquefy must be treated with amylase to break up the mucus to obtain an accurate sperm count. After liquefaction, normal specimen is watery and forms discrete droplets. The viscosity of the seminal fluid may be assessed while measuring specimen volume or when pipetting the specimen for other tests. The viscosity is often evaluated and reported in semi-quantitative terms. Normal semen is slightly viscous and dispenses in droplets, as shown in the picture on this slide. Abnormally increased viscosity will result in the formation of a string of fluid, and an abnormal decreased viscosity will result in the specimen's drops falling like water. In the microscopic examination of semen, standardization of procedures are very important, as is using experienced personnel. So you need to go through an additional set of training, because once you get into the microscopic analysis, some of these things are really difficult to assess. And the World Health Organization has the laboratory manual for the examination and processing of human semen, and it's an excellent resource. So what we're going to be looking at is doing a sperm count, looking at the sperm morphology, and determining the sperm motility. Through research efforts, more and more fertility issues have been identified in recent years, and as such, more testing procedures have been developed. Many of these procedures would be reserved or only performed in special cases or at laboratories that specialize in fertility testing. Of the tests listed on this slide, the evaluation of motility, the sperm count, and sperm morphology would be those that are more commonly encountered and will be presented in more detail. Although there may be comments or explanations on other tests presented, it is generally beyond the expectation for an entry-level MLT to cover them in any great detail. This microscopic exam is generally performed 30 to 60 minutes after collection. Liquefaction must occur and the motility of the sperm is observed. Motility is very necessary quality of sperm. They must propel themselves through the uterus and the fallopian tubes, which is quite a long distance. The motility will decrease over time, and the sperm are evaluated by motility as high, low, or non-motile. At least 80% of the sperm demonstrate some forward progress in a normal semen sample. One of the first observations to be made is agglutination. And agglutination, or clumping of the sperm, specifically refers to motile spermatozoa sticking to each other, either head to toe, tail to tail, or in a mixed way. They are live and kicking. Clumping may be observed while evaluating a wet mount of semen for sperm motility. A few clumps of sperm are normal. True agglutination occurs if sperm are distinctly clumped head to head or tail to tail. This indicates the presence of anti-sperm antibodies, which is a really bad thing. And this is found both IgG and IgA antibodies in men with reduced fertility. So if they're making antibodies against their own sperm and the sperm is clumping, there's no way they will have the motility to go forward and fertilize the egg. As texts, we also examine the viability of the sperm. And in your textbook, they use the term vitality, but most places I've worked at call it viability. The sperm are stained with two stains that are listed on the slide, and a dark background with red-colored sperm are indicative of dead sperm. Sperm that are white and colorless are viable sperm, living sperm. You will count at least 100 sperm heads, and they're counted in the two different categories, just like if you were doing a differential. You'll have a living category and a dead category. The normal values for viability are 75%. Penetration is defined as sperm that may be incapable of penetrating through the cervical mucus. The presence of many motile sperm is evidence for normal penetration ability. This picture is in your textbook, and it uses the eosin nigrosin stain, and the white sperm are alive. Their membrane is intact. The pink stained sperm are dead. Their membrane was damaged as they died, and it becomes permeable to take up the stain. So the stained heads are dead and the white heads are alive. You count 100 of these and differentiate between the two. If during the cell count more than 1 million white blood cells per milliliter are counted, this indicates an inflammatory process and maybe even an infection. Immature spermatogenic cells may resemble white blood cells. This is why you need to be experienced and go through some really heavy training to be able to notice that these are not white cells, but that they're immature sperm cells. And the presence of red blood cells are abnormal, and additional investigations should be done. This figure is from your textbook, and it illustrates spermatozoa or sperm. In figure A, we have the schematic of a mature sperm, and you need to know the three components: the head, the midpiece, and the tail. And then there's an enlarged view of the head and the midpiece. A photomicrograph in figure C of a single sperm using phase contrast microscopy. In examining the morphology of sperm, this involves a subjective evaluation of three distinct areas of the sperm, which may be performed in cytology, pathology, or hematology. If you are associated with a very busy infertility clinic, then the techs at the bench will be very proficient at doing these. Otherwise, if you only do one a month or every so often, these need to be done somewhere else, either cytology or pathology, but by someone with expertise in doing a proper examination. First part you're going to look at is the head. It's oval and appears flattened when viewed from the side. The head length to width ratio should be 1.5 to 1.75, and approximately half of the sperm head is covered with an enzyme-laden acrosomal cap, which aids in penetration of the egg for fertilization. The neck piece is attached to the middle piece or mid-piece of the sperm. It is 6 to 7.5 micrometers long and thicker than the tail. This part of the sperm contains mitochondria for energy. The tail is slender and uncoiled. The tail piece is approximately 45 to 55 micrometers long, and it serves as a flagellum providing movement. In doing the microscopic evaluation of sperm morphology, each sperm is classified using 5 categories: normal, head defects, mid-piece defects, tail defects, cytoplasmic droplet present. This would be located in the mid-piece region and is abnormal if this region is more than 1/3 the area of a normal sperm head. At least 200 sperm are evaluated on a stain smear, either Wright's, Giemsa, or the Pap stain. You're looking for double heads, pinheads, giant heads, or amorphous heads, double, coiled, or missing tails. So there's a lot of aberrant morphology that can be detected in spermatozoa, and this may indicate a fertility problem. So this table illustrates some of the more common abnormalities seen in the head of the sperm as well as the tails. This is a diagram from your textbook and illustrates sperm morphology. So a normal spermatozoa is in the far left, and then there's variations of the different types of abnormalities that may be seen. And if you look at your textbook, it has the caption below to tell you what each of these abnormalities are called. At the MLT level, I want you to know normal, know those basic malformations that were noted in the previous slide. Another part of the microscopic examination is motility. This is very important since immotile sperm are unable to reach and fertilize an egg. It's evaluated subjectively or by an automated method. And subjectively means a person is looking through the microscope, and depending upon which field you're looking at or your level of expertise may vary from person to person. That's why this is called subjective. Automated methods are much more standardized. At least 50% or more of the sperm should show moderate to strong linear or forward progression. So this is the sperm motility grading. It goes from immotile to motile with strong linear forward progression. So you can see by these descriptions that you would need additional training in order to be able to grade the motility of sperm. Normal sperm concentration is 20 to 250 million per milliliter. This number always astounds me because it only takes one to do the job, but this increases or multiplies the chances by a lot. If you've ever seen a video of the sperm actually going through the vagina into the fallopian tubes, it's amazing because they get lost, they get stuck, they die, and then it's fascinating. And I would strongly encourage you to find a video that illustrates that concept. The concentration is determined manually by your friend, the hemocytometer. So the sperm count is determined by multiplying the concentration per milliliter by the volume of ejaculate. That's why the volume is so important. That's why you can't have a spill or a miss. Post-vasectomy sperm count should be 0 within 12 weeks after the procedure. Any remaining sperm should be non-motile. So this is a very essential, important test that a guy needs to go back over and over until the sperm count is 0. This is a picture I stumbled upon, and it kind of illustrates what progressive motility looks like, an abnormal motility where the sperm cannot move forward because they're going in circles, or an immotile sperm that absolutely does nothing, just sits there. Professional judgment should be used when determining the area to count on the hemocytometer. And again, this is where training is essential. The 5 small squares shown in red in the center square may be sufficient to obtain an accurate count when the sperm concentration is very high. Otherwise, it may be necessary to count the 4 outside corner large squares, or even one entire side of 9 squares to obtain an accurate count when the sperm concentration is low. So you load the hemocytometer up and you look and see how densely the sperm are on the hemocytometer. If they're very dense, fewer squares need to be counted. If there's not very many, then you may have to count more. Following the rules for the hemocytometer counting will require professional judgment as well, because sperm do not always lie entirely inside or outside the counting area, just like when you're doing a manual white count. What usually works best is to determine the placement of the sperm heads on the hemocytometer grid rather than the tails. You may count the sperm with heads that touch the upper and left borders of the counting grid and not count those sperm whose heads are touching the bottom and right borders. The picture representation on this slide shows what would and would not be counted, with the red X's being not counted. Using a hemocytometer is using a hemocytometer. It doesn't matter what you're counting. The standard calculation is used for calculating the number of sperm. This is an example of a cell count. So what I want you to be able to do is, given the number of sperm and given all the information needed to do a calculation from a hemocytometer, that you will be able to come up with a number. This is for your information only. I found this kind of intriguing, and it gives you the proper terms to use when describing certain situations with sperm. And the bottom one was kind of made me smile. Necrospermia, which means dead cells. Necro always means dead. There are a few chemical analyses that may be done on semen. The first is pH. You want to measure it within 1 hour of collection. The normal ranges are from 7.2 to 7.8. If the pH is below 7.2, then that indicates potential abnormalities of the epididymis, the vas deferens, or seminal vesicles. If the pH is above 7.8, this suggests an infection. Fructose is a sugar, and it provides energy and nutrition to the sperm. It is an indication of viability. It's produced and secreted by the seminal vesicles, most often measured when no sperm are seen on the count. Normal levels are greater than or equal to 13 micromoles per ejaculate. Zinc is measured to evaluate prostate function. The normal values are greater than or equal to 2.4 millimoles per ejaculate. Citric acid is also used to evaluate prostate function, and the values are normal, greater than or equal to 52 millimoles per ejaculate. Acid phosphatase is used to evaluate the secretory function of the prostate, or it's used in rape and sexual assault investigations to identify semen and vaginal fluid, as prostatic fluid acid phosphatase is higher than other fluids. This table is found in your textbook, and these are the semen characteristics that are associated with fertility. Look for some videos of different elements of semen analysis.